Shabbat on Saturday mornings. We've been members for about a year now, and we're often in the kids service with I've got two little ones, but usually try to pop over to the adult service at the end. So hope to see you all there soon. Yeah, so I just wanted to share some of the work that we've been doing over the last few months around COVID, and I was asked to talk for 15 or 20 minutes, and then we can sort of just chat about any questions that you might have. And I've gotten a lot of emails from Becky members asking if they can go see their grandparent or their grandchildren. So that's probably going to be the most common question, I think. But we can get there in a little bit. So I've got some slides I can bring up, and let's see. Yeah, so I think everybody is sort of an expert now in COVID, just because it's everywhere in the news and you really can't escape it now. But just to sort of review, quickly where we are in terms of the epidemic in the U.S. We really started to have some experience with COVID in the U.S. in early February. So that's when sort of the first death was reported. This was done by sort of an autopsy that was sort of done retrospectively, and the earliest death that we've identified in the U.S. was from early February. In this part of the country, obviously, we all experienced sort of what happened here, and really explosive growth. Starting first in New York and then radiating out to our parts and more rural areas. Obviously, other parts of the country have had a very different experience, and in some places had very slow growth and are obviously now seeing pretty strong upticks. So this picture is a couple of weeks out of date already, and I mean it doesn't have sort of the increase that we see elsewhere in the U.S. But I mean in this part of the country we're in pretty good shape. This plot on the left is showing the sort of number of cases over time in New York, and it's was really bad in April and has tapered off to almost nothing now, which is great. Other parts of the U.S. didn't have quite the same explosive growth as in the Northeast, but are now starting to see these sort of second emergence of the epidemic. So one of the things that we try to do is we're really data people in my group, and we're trying to sort of understand sort of the best ways that we can sort of track the spread of the epidemic. And it's especially with an emerging pathogen like this, it's really important to have good data. And this is important because we need to be able to detect new outbreaks and new clusters that might be happening. So if there is a reemergence of COVID in Connecticut, we want to be able to detect that as quickly as possible and try to intervene in any way that we could. It's also important to track whether some of these measures that have been put in place, like social distancing and closing restaurants and face masks, all these things are actually working or not. And of course, one thing that's been really important from a public policy point of view is sort of at what point is it safe to loosen the restrictions and start to reopen things. And we've been very cautious in Connecticut and the Northeast, and have really waited until the epidemic was sort of on the downswing before we reopened things. Some other parts of the country really didn't get to that point and sort of reopened at a point where they were still having sort of a lot of transmission in the community. So there are a lot of data sources out there. If you sort of watch cable news at all, you see these tickers that are always up there about how many people have died and how many infections there are across the country, how many sort of hundreds of thousands, or I don't know what the total is now for number of people who have tested positive for COVID, how many people have been hospitalized, and how many people have a death that was attributed to the virus. But these traditional data sources all have limitations. It can often be very slow to get the data. They have to be processed by the health department. And there's often sort of a lag between when a case occurs or when a death occurs and when we find out about it, and when it's reported to the public. These data sources can also be heavily biased, and we'll talk more about that as well. And are really dependent on how you're doing your testing, who you're testing, how available that is. And in places where they don't have sufficient capacity to test, it might be undercounting cases. If you're really focusing your testing in high-risk populations, like in homeless shelters or in nursing homes, then it's going to look a lot worse than if you're sort of testing the general population. So one of the things that we think a lot about is sort of alternative ways that we might be able to track the spread of the epidemic. And there are a few different data streams that we look at. And these are sort of, we refer to these as syndromic surveillance. So instead of looking for the number of people who have coronavirus, who have a positive test for coronavirus, we're looking at things like how many people are visiting the emergency room with a complaint of cough or of fever. And likewise, we can look at how many people have been calling the ambulance for breathing problems, and how has that been changing over time. One thing that's been sort of a novel thing that we've been working on here in New Haven is trying to look at sewage. So, can we actually detect the virus in sewage, and does that tell us anything about the transmission of the virus in the community? And finally, people searching, everybody's sort of searching for information constantly. And there's a huge amount of data that are out there about sort of what people are searching for and any concerns that they might have. And we can potentially use that information to tell us something useful. I see there's a couple of questions in the chat window, so maybe I'll pause here and see it. So Donna asks if I've seen death certificates where the primary cause of death is listed as heart issues and coronavirus is listed as a contributing factor. Are those deaths kind of as coronavirus deaths? Great question. We're going to get to that in about 2 minutes, so I'll come back to that. Oops. And then deaths is so tracking how many people are dying of things. Instead of looking at coronavirus deaths, as the question alluded to, we can look at how many people are dying of pneumonia instead of how many people are dying of coronavirus, and that can potentially tell us something about what's happening as well. So just to give you a sense for how this looks, we've been sort of setting up these systems and algorithms to try to detect these outbreaks in different places. So this is data from emergency room visits in New York. New York has some of the best data, public health data in the country. And this is showing us emergency room visits for people who have influenza-like illness in New York City. So this is like fever or cough in different age groups. So if we look at children, which is this upper left-hand graph here, we can see the black line is how many people actually visit the emergency room in each day for influenza-like illness. And the red line is how many people we would expect to visit the emergency room based on sort of how many people usually visit the emergency room that time of year. And what you can see is that, starting in March or so, the number of kids visiting the emergency room actually plummeted. It went way below historical levels. So the black line is way below the red line there. If we look at adults, though, so these are 18 to 64-year-old adults. These are sort of young to middle-aged adults. The black line just shoots up way, way, way above the baseline. So this is the sort of increase in emergency room visits that we see. Most states have these types of data, so we worked with the Connecticut Department of Public Health to track these data in Connecticut. And it was amazing. I mean, the data are available, within minutes of somebody being admitted to the emergency room, and we could basically just see, just tracking people with cough, people with influenza-like illness. We could just see sort of the epidemic progressing up the coast. We saw it in Fairfield, and then a day or two later, we could start to see it in New Haven, and then sort of just spreading out from there. So, it can provide really valuable information about the spread. These data sources have their own biases. Sometimes people are more likely to go to the emergency room if it's if they're hearing about it on the news and are panicking and so forth. But it's sort of one more, tool in the toolkit, and it's readily available. And we've got another question for Harriet. The question is why we don't get info about how many people have recovered. So many people have it now. so many people are tested positive. Yeah, so the question, I guess, is information about recovery. Yeah, so it's tricky to track that because we can probably do that now because enough data has accrued. But so we get the testing data, which is when people first encounter the healthcare system, and then it takes some time for them to die. So there's sort of this lag. So it can be challenging to sort of just look at how many people have tested positive and how many people have died, and to do that comparison. But there are estimates out there now about sort of the fraction of people who have been infected who die, and the best estimates now are about 0.5% to 1% or so of people who are infected with the virus will die. So another way to say that is 99.5% of people who get infected will recover. So that's the good news. The bad news is that when you actually do the math and figure out how many people have been infected and how many people might become infected, that's actually a lot of people, even that 0.5%, and it's sort of much worse than what you would see during a typical flu season. And we expect that probably a lot more people are going to be infected than you would see during a typical flu season as well. Okay, yeah, and just going back to the sort of different data streams we have, we can look at ambulance calls as well. So this is showing us, and again, this is a data stream that's already being collected. You don't have to go out and spend money to collect these data or any resources. So this is just people who are calling 911 and with a complaint of breathing problems in Phoenix, Arizona. They update their data regularly on their website. You can sort of track this day to day. And what we can see is that there's this huge spike above sort of what we expect in March and April. It sort of returned to baseline, and then you can see sort of late May, early June, this increase, and that's really sort of consistent with what we're seeing in sort of the traditional public health data, where we have these sort of large increases in reported cases. Yeah, so Eva just put in the chat that 0.5% death rate would mean about 1.5 million Americans. Yeah, so that, of course, it depends on how many people ultimately become infected and what that profile looks like, and so forth. We wouldn't expect that the entire population is going to be infected by the end, but certainly, the projections have been dire, and this is why we're sort of going through all this hassle that we're going through right now. So another thing we've been sort of trying to track is virus and sewage. So it turns out that people who are sick with coronavirus or infected with coronavirus actually shed the virus in their stool. So this concept has been around for a long time for other diseases where you basically, instead of going out and testing a whole lot of people in the community, what you do is you collect sewage you collect sewage, or in some cases you can sort of collect it closer to the source. But so what we've been doing, this is my colleague Jordan Peccia, who's in the School of Engineering, is he sends a team every day down to the sewage treatment plant, which receives sewage from New Haven and North Haven, I think Branford. There's a sort of 4 towns that where the sewage sort of flows into this sewage treatment plant, and they get a sample of sort of condensed sewage from. It's completely disgusting, but what they do is they get a sample of sewage, they bring it back to the lab, and then they test it in the lab. And what we found by doing these tests is that if you sort of look at the concentration of sewage in the the concentration of virus in the sewage, or the concentration of viral RNA, so this is not necessarily live virus, but sort of pieces of the virus in the sewage. And then we look at sort of the reported number of COVID cases in these same 4 towns. what you see is it lines up really well, and the red line, which is the sewage, tracks ahead of the reported cases by about 6 days or so. So it potentially gives us sort of an early warning sign of when things are increasing. So the good news is that out to about 2 days ago, the levels of virus in the sewage were very, very low. So, you know, basically as low as they have been since we started tracking this back in March. So, you know, that's sort of a reassurance for us that, you know, we don't have a lot of you know, undetected spread going on in the community here in New Haven, which is great. I think there's another question in the chat. Okay, so the question is, assuming the death rate of diagnosed infections in countries like Israel and New Zealand should be similar to the death rate in Connecticut adjusted for age, extrapolating to the deaths in Connecticut suggests something like 25% or more of Connecticut residents have already been infected. What percent of Connecticut residents do you suppose that, yeah, so what percent of people have already been infected? So that's difficult. So you know, the best way to try to measure this is by serosurvey. So where you basically go and, you know, test people's blood for antibodies against the virus. So we see if people have an immune response. When they've done this in New York City, you know, in some of the hard hit boroughs in New York City, they see that something like 30% of people have been infected. You know, less so, you know, so that's like, you know, looking at Queens and the Bronx where they had really high infection rates. I haven't seen good estimates for Connecticut. Connecticut was certainly hit hard. It wasn't hit quite as hard as New York City. And I think it probably varies quite a bit depending on where you look in Connecticut as well. So, you know, certainly, you know, there have been huge disparities between populations. Mark Abraham, who's a Becky member that many of you know, has done some great work on this, sort of just showing, you know, how much sort of more this the epidemic has hit sort of low-income communities, and you know, even, you know, within New Haven, you know, if you compare the infection rates between you know, sort of Dwight and Westville, which are, you know, or even Edgewood and Westville, which are, you know, a mile apart, you know, you see these huge differences. You know, we really haven't seen a lot in Westville, but other parts of New Haven have. So, you know, I'd imagine that you know, there are parts of New Haven where maybe we're hitting those you know, that you know, 20 to 30% rate, and probably other parts where we haven't. Certainly the death rate also, you know, varies a lot by age and by underlying condition and socioeconomic status, and so it can be difficult to sort of make these sorts of direct comparisons between locations. And just really quickly, this is not sort of a formal analysis, but this has been in the press a lot. We've been doing some more formal analyses of Google search data. It's tricky to use, but this is, somebody noted this a couple months ago, that people without, who are infected with coronavirus seem to have issues with smell. And it turns out if you just sort of look at trends in searches for problems with smell, it actually tracks really well with the epidemic curve. And like, so this is for the US as a whole. And then down here, this is Florida, and you can see Florida is sort of increasing over the last couple of weeks, which does correspond with you know, what we know about what's happening down there. There are a lot of issues with using the search data, and needs to be used very carefully, but yeah, it's potentially another tool in the toolbox. Okay, so getting back to the question from earlier, so tracking deaths. So sort of why track deaths? I mean, first of all, that's what everybody cares about, right? I mean, we don't necessarily care if people get sick if it's not severe, and it, you know, if there aren't sort of long-term consequences and so forth. It's also possible that counting deaths is somehow less biased than counting cases. Oftentimes death certificates, the criteria for sort of, you know, recording something, a death is due to the virus is a little bit more standardized. There are still a lot of issues. But, you know, as was alluded to in the question, you know, the official COVID death numbers themselves have some serious problems. So the criteria for defining whether a death is due to COVID or not can vary a lot between states. So like New York City, if there's even a suspicion that the death was related to COVID, then it can be recorded as a coronavirus death on the death certificate. Other states are more stringent, where you actually have to have a viral test that tells you that it's positive. There are a lot of other issues. You know, so if you don't have testing, you obviously can't sort of attribute the death to coronavirus. And yeah, so sort of so one solution is to sort of look at sort of broader categories. So instead of looking at coronavirus specific deaths, we look to see whether you know, deaths due to any cause have increased, or deaths due to something like pneumonia, which we think is caused by or related to coronavirus, have increased. So in the US, you know, when the death certificate can be filled out by a clinician, usually a physician, in some states a nurse can fill it out. When the death is due to natural causes, usually when it occurs in a healthcare setting. If the death is unattended, so if somebody dies at home, then the death is the death certificate is completed by a medical examiner or coroner. So determining what somebody died of and how to fill out the death certificate is sort of an art. So you know, as was raised in the question, you know, you could have coronavirus listed as the primary underlying cause of death, and you might have pneumonia listed as a contributing cause of death, or cardiac arrest as the contributing cause, or the other way around. So you might have pneumonia listed as the primary cause, or coronavirus as the secondary cause. You know, as has been raised, you know, there are certainly issues where, you know, people die of something completely unrelated, and they happen to have a positive coronavirus test, and that might end up on a death certificate as well. So, you know, there's certainly issues with the data quality. You know, so officially the CDC recommends recording whether, you know, recording a death is due to coronavirus, even if there's just a suspicion that it's due to coronavirus. But again, whether this happens or not varies by state. And the data are, so the death certificates are registered by the state, and then they're basically reported to the CDC. So the CDC sort of combines together the state level data, but the sort of from a legal standpoint, the states are the ones who are responsible for those data. So we started this analysis back in April, or yeah, first week of April or so. And you know, I worked with a group that I've worked with for a long time from the NIH. And you know, we've done a lot of work on trying to estimate this type of you know, relationship between viral epidemics and deaths for influenza and for RSV, for other pathogens. And I had no idea that it was going to become so politicized. It's been unbelievable, sort of the degree to which this has sort of become a sort of political hot potato over the last couple of months. You know, so this has been, I don't know, you know, I'm sure we have a diversity of, you know, which news sources people consume among the Becky members, but I mean, you know, so, but you know, wherever you look, there's, you know, sort of questions about sort of the severity of the epidemic, and depending on whether you're sort of on the right or left, sort of questioning whether the counts are too low or too high. And it's crazy. So my favorite headline here was Trump warns U.S. coronavirus death toll could reach 100,000 as Yale experts warn it already has. That was our study. And yeah, it's been crazy. We had the White House actually reached out to us after we sort of published our initial findings, sort of asking for very detailed questions. And we never sort of got a lot of follow-up after that, but I'm guessing they weren't sort of asking because they really were hoping for, you know, I think they were probably trying to find holes in the analyses and stuff, but we never really got a lot of follow-up on that. We've done a lot of work sort of as part of this with the Washington Post over the last couple of years. So this is a story that we ran with the Post about a month ago. I'm trying to estimate these sort of increases in deaths. So just to sort of, you know, give you a little bit of background as to why we think that the deaths are probably an undercount, so that official tolls. So again, we're mostly working with influenza, and so this is really well known for influenza, that the sort of deaths that are attributed to influenza are really a large undercount. And, so if you look during a typical flu season, when you see flu spike, you also see spikes in things like heart attacks and pneumonia deaths, and even things like diabetes deaths spike when flu spikes. So flu's not necessarily getting credit for the death, but there's sort of these clear increases that coincide with severe flu epidemics. Especially early on in the epidemic, is the coronavirus epidemic, we weren't testing a lot. It was pretty hard to get a coronavirus test. And so, we think that probably contributed to undercounting. And again, the sort of criteria for coding deaths is pretty uneven between states. So just to give you sort of the top line finding, which this was actually just published today, and it's been in the press a little bit, where, so we basically looked at the period from March 1st until the end of May. And over that period, there were 95,000 deaths that were sort of recorded as due to coronavirus. And we're estimating that the sort of full total is 122,000 deaths. That leaves a gap of about 27,000 deaths. Some of those deaths are, we think, actually caused by coronavirus and weren't recorded as due to coronavirus. Some of those deaths might be due to other things, like we know that people stopped going to the emergency room for heart attacks, and so we think that there's probably some increase in deaths due to heart attacks that just isn't getting picked up in the official data. But we think a pretty good chunk of that gap, of that 27,000 missing deaths, is actually due to the virus directly. This varies a lot between states. So, you see these huge increases in the Northeast, Midwest, and some other states like, Florida, even though, it's a large state, so they had in absolute numbers, they actually have had a lot of more deaths than you'd expect this time of year, but it doesn't really, it's not huge. It doesn't really hit you over the head. And I think this is my last slide. So, and then I'll get to, I think there's a couple more questions. So we're continuing to follow this. There's been recently, there have been questions about sort of this increase that we're seeing in the Southeast and southwestern part of the US, these really sharp increases in numbers of cases. So far, we haven't seen like a really large increase in the number of deaths, and people are wondering why that is. And we think that part of the reason is that it just takes a lot longer. There's this lag between when people get sick and get detected, and then when they die and when that death gets entered into the system. So we've been sort of tracking the deaths over time, and just Arizona is one that's sort of notable, where we are starting to see an increase in the number of reported deaths. So just this gray shaded area is showing us the excess deaths in each week, and you can see sort of in the last 2 weeks those deaths are starting to inch up. So we're following this closely, and we're going to sort of see what happens. So just to finish up, I think we're using some of these non-traditional data sources, these syndromic data sources, which we think can complement traditional public health and give us really good up-to-date information. And that sort of getting an accurate picture of the spread of the epidemic is really important in terms of thinking about how to proceed safely with the reopening and everything. So let me see, I've got a chat in the window. Yes, so a couple questions. So I see, so have overdose deaths increased? Yes, so the problem with overdose deaths is for administrative reasons, it takes a lot longer to actually code the overdose deaths. So the data is just now starting to come out about overdoses, but there have definitely been increases in overdoses. that are pretty substantial. I saw a news report this morning from Cook County in Illinois, and it was a pretty substantial increase. I think they had, I think typically, they had something like, 500 overdose deaths during, during the epidemic period, and I think they were up to like 700 or something. So, it's a pretty substantial gap. How much that contributes to the overall totals, I'm not sure. We're going to have to wait until sort of more data come out.
Dan?
Yep.
If you could excuse me, I think there are a couple more questions in chat, but I think so that we're a little more conversational since we're going to be doing question and answers right now, rather than your presentation. Maybe if people have a question, just let me know, and then we'll call on you and you can ask the question yourself rather than Dan having to read every question. That way all of us are hearing it all together. How's that?
Yeah, great idea.
Okay, so let me read the couple of questions that just came in, and then if you want to add questions, just say you have a question, put in the chat that you have a question and I'll call on you, okay? So Gila has Gila has a question. She said, any thoughts on whether antibody tests are useful to individuals at all? Had you seen that question already, Dan?
Yep. Yep, happy to field that one. So I think the jury is still out as to how useful they are. I mean, certainly it gives an indication if you've been exposed. There's some evidence now that antibodies disappear fairly quickly, which is discouraging. We don't know if that means that you lose immunity or if that you just can't detect the antibodies in the blood. But so, it's possible that, if you wait too long that you might have been exposed and you might have some immunity, but it might not be detected on an antibody test. Short term, I guess it might provide some peace of mind if you're gonna, be seeing your grandparent or your grandchildren or something, and you have a positive antibody test. Maybe that provides some peace of mind, but we still don't even really know what a positive antibody test means in terms of your individual protection. So, I think I would be cautious about reading too much into it at this point. There's just too many unknowns about sort of how to interpret those data.
Okay, David had a question. David, do you want to unmute and ask it, or do you want me to go ahead?
Dan, do you find that there are certain countries that you think are doing a better job of gathering data? And if so, what is it that they're doing that you think makes them more effective?
Yeah, I mean, I think even within the U.S., there's huge variations between states in terms of the quality of data. So New York City is and has been for a long time sort of a leader in collecting excellent public health data. So they do intensive testing. These electronic health systems, so like the emergency room data streams they've had coming in for many years. They really know how to interpret them well. Yeah, so I mean, I think having sort of a strong public health system is important. In terms of death statistics, I mean, New York City has electronic death reporting, so within a week of the death occurring, we have pretty much almost a complete picture of how many people died in the previous week. In many states, if you go to South Carolina, going out to several months after the death, we still are only capturing a fraction of the deaths. So that's an issue. To some degree, it comes down to sort of investment in electronic databases and data collection systems. I think it also is related to sort of how much we're able to invest in sort of testing in the community and so forth. But I think that, certainly the Scandinavian countries are always in the public health world the envy of the world, just because they have excellent systems for sort of tracking healthcare visits for the entire population. So they can really tell you for every individual in the population, sort of, whether they've been sick, and so that makes everything a lot easier in terms of things like contact tracing, finding out who's been in contact with an infected person, and all these things become easier when you sort of have more complete data systems. In the US, it's challenging. Public health is done at the state and local level in the US. So it's difficult to have sort of coordinated programs, for the entire country. But, we're definitely better than we were 10 years ago, but still have a ways to go.
Great, thank you. Our next question comes from Eva. So Eva, if you can unmute.
Sure, thank you. There's talk now about swine flu crossing over from the pigs to humans in China. What effect do you expect for that to have on coronavirus and our measurements?
Hopefully not much. So there's constantly sort of flu viruses that are crossing over from animals to humans and from humans to animals and back again. And it seems like every few years we have, a sort of scare where there's, some animal virus that, crosses over to humans, and then, maybe causes some short transmission events. But, so far, that virus hasn't shown, evidence of extensive transmissions, and hopefully it'll stay that way. But I mean, I guess on the plus side, everybody is hyper alert now. So, it would probably not go undetected for long. I think there's just so much testing going on around the world that it would hopefully be a little bit easier to contain. And that's oftentimes the key with these things, is being able to tamp it out early on. So, but in terms of globally, there hasn't been evidence that this is spreading widely. So, hopefully it won't, have any impact beyond sort of the local population where it's been detected.
Our next question is from Rachel Edelstein. Rachel, if you could unmute.
Yes, thank you. So what I'm wondering is what kind of tests are currently available to individual people, and how accurate these tests are. And if there's a choice, which test should you get? Yes.
So most of the tests that that are available now are, the deep nasal swab, where they basically, it looks like they're poking your brain, like, they sort of stick this swab up your nose as far as it goes until it hits the back of your throat. And in terms of the approved tests, those are currently the preferred version. In terms of how accurate they are, it depends a lot in terms of how long it's been since you've been exposed and where you are in the course of illness. So, if you've been exposed in the last couple of days and have just sort of recently acquired the infection, then the sensitivity is very low. So, maybe like less than half the people who are tested will come back positive. If you're showing symptoms and if you're showing symptoms and sort of are in the early stage of the illness, then sensitivity is quite a bit better. It's sort of 80% or maybe even higher of the people who are tested who actually have the virus will come back positive. And then it sort of tails off again as your body starts to clear the virus. The sensitivity of the tests decrease. So that's in terms of what's available now. There are some saliva-based tests, which I think are really exciting. Some of my colleagues at Yale are developing this right now, where you basically spit in a cup. And it turns out that that's even more sensitive than the one where they stick it to the back of your nose, and obviously much more pleasant. They're hoping that they're working on getting approval from the FDA for that test right now, and hopefully within the next couple of weeks that'll have authorization. There are some sort of limited places where you can get the saliva test done, but it's not as readily available right now.
Thank you.
Our next question is from Jay.
So let me ask you very specifically, a 4-year-old who's going to JCC day camp what are the chances that she has an asymptomatic infection? If you can't give me that specific data, give me a general idea.
So in Connecticut right now, the community transmission rates are very low. I don't know if I can give you a number, but I would say the chances are low, right? We don't have a lot of transmission going on. If they're coming from Westville, especially, there's not a lot of transmission in surrounding suburbs. So I think that the risk is pretty low. My daughter, who's 4.5, is goes to gymnastics now once a week, and I'm not too concerned about it. They take precautions and keep the kids apart and stuff. The risk is always that somebody travels to South Carolina or Georgia or Florida, comes back, goes to camp, and then you get an outbreak. We still don't know a lot about how important kids are for transmitting the virus. The kids they're more likely to be asymptomatic if they're carrying it than adults. So, if they're infected, it's more likely to be undetected. But I think I would feel okay about it on a personal level. I mean, if my daughter's camp that she usually goes to is open, we probably would have sent her. And then just been extra cautious in terms of visiting my parents and stuff afterwards. But yeah, I think the individual risk is pretty low right now, fortunately. And there's a lot of, yeah, sorry, go ahead, Jay.
Has anybody just done surveys of kids to see what the prevalence of asymptomatic infections is?
They have, and the issue is, it depends a lot on what the community rate of transmission is. So, what they found is that, if you do a prevalence survey, a population where there's an active epidemic going on, the rates in kids are pretty similar of infection are pretty similar to the rates in adults. So it's not like the kids are immune from carrying it. They might have lower viral loads than adults. But again, the community transmission is pretty low right now, so we'd expect that the pediatric prevalence would also be pretty low as well. Yeah. There, of course, the risk is though that there could be an outbreak in the camp, and and then obviously it skyrockets. But just a random kid going to the camp who hasn't been at the camp for a long time is, they're probably risk of being an asymptomatic carrier is the same as any of us, which is pretty low right now, but we like to keep it that way.
Thanks. Eva has a question. Eva, can you unmute?
Okay, thank you. I saw that Israel reported they had developed a 1-minute test for coronavirus. Do you know anything about that? And are we expected to ever get it?
I don't know about that one specifically. I mean, this is a very hot topic now. Obviously everybody wants to sort of have these rapid tests available, and there's sort of talk of these, these ones that you can do at home and so forth. Yeah, so I mean, I would say that I'm optimistic. I don't know about that test specifically. I'm optimistic that we'll have some rapid tests within the coming months, but I don't know if it'll be a minute, but even 15 minutes would be great. Currently the technology mostly involves, taking a sample back to the lab and processing it. So, there's at a minimum several hours, lag time, and often, several days. So anything that we can do to speed that up would be great. We've been thinking a lot at Yale about ways to do that and to try to develop some of these rapid tests. But yeah, I think it's still a little ways off. I mean, even if they develop a test, the challenge is sort of scaling it up, and you can imagine the demand is going to be massive for any sort of test like that. So just getting the production capacity together is going to be a major challenge. But I hope that we have it soon. I'm hopeful by the fall that we'll have some better options for testing.
Hi, can I ask? I guess I can ask my question.
Yep.
So I was just curious, when there is a vaccine at some point, Daryl, I think you're on mute. When there is a vaccine at some point, do you think that it'll be like rolled out sort of to high priority populations first? Like, I don't know, like everyone in the nursing home gets vaccinated first, something like that. And what do you think about that?
Yeah, there's, I mean, a lot of discussions about sort of how you would prioritize that rollout, because again, there's going to be huge production issues. You know, if you think just in the US, you know, population of 300 million plus, you know, that's a lot of doses of vaccine to produce pretty quickly. So you have to prioritize. I mean, for when this, you know, this isn't a new problem. This comes up, you know, when, you know, in the past for, you know, when we've had flu pandemics and so forth, and who do you protect first? Often, you know, the healthcare workers are the sort of first ones to prioritize because they're sort of the most likely to be exposed, and they're the ones that you really need to protect to sort of maintain the integrity of the health system. But yeah, then I think sort of rolling out to other priority high-risk populations, elderly, nursing home populations, of course. Depending on, you know, we still don't know a lot about transmission. You know, there's been some suggestion for, you know, influenza that you should prioritize like preschoolers, because we think preschoolers are really important for transmission. So, you know, that might tamp it down, but it's not clear that that's necessarily the case for coronavirus. So yeah, you might just want to focus on people who need it the most.
Okay, our next question's from Donna.
I
Donna,
actually have
unmute.
two.
There you go.
Yeah, I actually have two, if I may. I was trying to signal you, Daryl, that you were muted before. First question, as a relatively someone with risk factors, I recently added to my risk factors type A blood. So how significant is that really?
Yeah, so there's been this one study that came out where they basically looked for genetic factors, and yeah, type A blood was one of the ones that came out. I think it's hard to say at this point. You know, there's tons of research coming out right now, and I'm skeptical of anything until I see the results really repeated several times in different populations. So, you know, I think I wouldn't lose sleep on it yet, and you know, just I think be cautious. But
Okay, so the second question, and as a perfect segue in terms of being cautious, we're planning to see our Massachusetts grandchildren for the first time in 4.5 months this weekend, and stay at the same resort,
yeah,
along with our Connecticut grandchildren and children. The children are all being tested. The adult children are all being tested. The grandchildren, the tests weren't available as readily. They couldn't do it. So now the discussion going on, even as we speak on my iPhone amongst my daughters, is which should the grandchildren wear masks when we're indoors? Which apartment should we, there's two apartments. Should we stay with the Connecticut daughter or the Massachusetts daughter? With the Massachusetts daughter's kids are 1 and 3, so and the other ones are a little older. So the 1-year-old obviously won't wear a mask, and can I hold him? All the grandparent questions.
yeah. So I, you know, I have two little kids and grandparents that desperately want to see the kids. So I think so that's great. They got the testing. I think so.
They haven't gotten
Oftentimes
the results yet.
when there's one positive person in the household, or one person who gets infected in the household, it's very likely that most of the household is going to get infected. So, you know, having a negative test in the parents is a good, definitely a reassuring sign. Doesn't guarantee that the kids aren't infected, but it's I think a good sign. I mean, fortunately, and it sounds like everybody's coming from Connecticut, Massachusetts, which are, you know, low risk areas right now.
Oh, I have a son that was in Texas, but he hit the road and got out of there
Okay,
about a
good,
week
good.
ago.
Okay,
He's
so
in
yeah, maybe
Illinois
he
now.
can.
That's as far as they could drive.
So yeah, he can get tested before he comes to see you all. But I think, yeah, I mean, you know, there's this idea that, you know, if you're in a bubble, you know, if all the if all the grandkids are sort of not, you know, are mostly staying at home and the parents are mostly staying at home, and you confirm that they're, you know, that they don't have a positive virus test, then, you know, the risk is probably pretty low.
So you're
Uh,
saying skip the masks? I know I won't hold you personally responsible, but
yeah, I mean,
would you?
I think I would,
I
yeah,
mean,
I
I'm
think,
inclined for me and my husband to wear masks, but not make them do it. And I know they say masks are to protect the others, but nonetheless,
yeah, I mean, it sounds like a pretty low risk situation to me, and it sounds like everybody's being pretty cautious in terms of being tested, and, you know, not knowing sort of what everybody else's contacts are and how much they're isolating. It's hard to say for sure, but
well, the younger ones have a nanny coming in every day whose contacts they're not tracing. So
yeah,
we don't know.
yeah. So yeah, it's hard to sort of give a firm answer. I mean, I can tell you what we've done in my
Yeah.
family. I mean, we you know, I brought the kids up to see my folks in Massachusetts a couple weeks ago, and you know, we hung out on my parents' back patio, and you know, we went in the house a little bit. My parents were not wearing masks, and we weren't wearing masks, but you know, they were sort of keeping their distance. They weren't snuggling the kids a ton, but my mom has a million comorbidities and stuff though, so she's, you know, being extra careful. We had a Shiva last week, which was not good. You know, we were indoors with 15 people, which wasn't planned, and it was that I don't recommend doing that. You know, they're from 3 different families, and, you know, so that's yeah, I would be careful about those types of situations. But it sounds like, I mean, it sounds like everybody's sort of putting a lot of thought
Yeah.
into it.
Can I add one more question of general interest that I think?
We do have quite a few more questions, so if we can make it brief, Donna?
Yeah, no, it's just in terms of the types of masks. They're just starting to come out with studies about which are most effective. I just heard on the news tonight. Is there a place where you could go and buy masks and get a rating on it? Like, you know, this mask is a 2, like you do with suntan lotion, you know?
Yeah, that's a good question. I haven't seen that. I mean, you know, from what I've seen, even just the simple cloth masks, you know, if you're actually covering your nose and mouth, are reasonably effective at stopping things. You know, but yeah, I haven't seen that. You know, I know there's like all these
Good
sites
business
now
for
with like
somebody rating masks.
yeah, it's not something I've looked into, but I'm not sure.
Pardon?
Okay, oh, I'm sorry.
I'm
You
sorry.
done? Okay.
Yeah, I just didn't hear.
Harriet had a question. She was next. Harriet, are you still here?
Yes, I'm here. My question was, you're talking about, so I was curious, I was the one with the cumulative numbers, which are not particularly meaningful in a day-to-day basis. And so you're talking about the community infectiousness. And so I was curious, what are the numbers that are going into your evaluation of the fact that there's not much community spread? I mean, what's the prevalence numbers that you're coming up with? Where are you getting that from?
Yeah, I mean, I think there's, you know, a number of different sources. I mean, if you look at, you know, the percentage of tests that are being done in Connecticut, Massachusetts that are coming back positive for the virus, you know, on a daily basis, they've been going down and are you know, fairly low right now. You know, our sewage test is not picking anything up, which seems to be a pretty sensitive indicator, which suggests that there's not a lot going on in the community. And, you know, basically by, you know, all the measures that we have, you know, hospitalizations are trending down. That obviously lags between the sort of infections, but, you know, that's heading in the right direction. So, you know, ideally what we'd be doing is, you know, testing a random set of the population every, you know, every few days or something, but that's, you know, we're not set up to do that at the moment, at least in the sort of citywide level or statewide level.
since we are coming up on 9 o'clock, we have 3 more questions in the queue right now. Shoshana, then Gila, then Helen Rosenberg. So I think that we'll go through those. Gila, you asked your question already, correct? Okay, so we have 2 more. We have Shoshana and then Helen Rosenberg, and then we'll wrap everything up. So Shoshana, why don't you go ahead?
Yeah, my question actually follows along what you were just talking about, which is for asymptomatic. We know that there's a fair amount of asymptomatic people out there, and who, when, and how often should people be screened, be tested?
Yeah, that's a difficult question. We had a 2-hour phone call yesterday trying to figure that out. I think it depends on what the goals are and what the the scenario. Basically what the goals are. So, we're bringing the Yale, or some fraction of the Yale undergrads back in September, and the Yale, so the Yale campus is going to be coming back to life. Faculty and staff are going back soon, and there's going to be very intensive efforts to test people on a regular basis there. So trying to especially kids who are living in dorms, are going to be tested, I think, weekly or so.
Oh, wow.
That obviously depends on having tests available. It's not cheap to do that, so forth. But, you could also imagine, like, Westville Community Nursery School, down Westville Village, they've got 30 kids, and, it'd be great to be able to test them every few days, or, once a week or something to, they have some older teachers and stuff, but, sort of resources, what resources
Right.
are available. If this type of, we were talking earlier about sort of these rapid tests, and, if those become widely available, it sort of changes the equation. If they're cheap and widely available, it becomes much more feasible to go out and, test, a quarter of New Haven's population every, couple of weeks or something, just go out in the community and ask people to provide samples. Where we are now with the volume of testing that we can handle, and sort of just processing the samples and everything, that's not feasible at this stage. But, ideally you'd be going out and, if the goal is to really tamp down transmission and sort of catch clusters before they take off, you'd probably want to be doing very intense sampling, going to a classroom, multiple times a week even, to do this. So, hopefully the technology will sort of be in place in the near future to be able to do that. Right now, it's there isn't really there aren't strong recommendations for asymptomatic testing, because we just most organizations, and municipalities and so forth can't handle that volume.
Thanks. I actually did get one more question after Helen. So first Helen, and then Jesse, and then we'll wrap up, okay? Helen, why don't you go ahead?
Okay, so my question is, what is the status and efficacy of contact tracing? You've heard a lot about it, but not actually how much use it's been.
Yeah, so I think contact tracing is sort of one tool in the toolbox. It's not a silver bullet. And I think contact tracing is, this is a sort of classic public health tool that's been, it's used for sort of outbreaks all the time, where you basically detect a case and then you try to find everybody they've been in contact with. The way it's been used in the past, it's usually used when there's sort of a limited outbreak, right? So there's, an event that happens and you want to identify all the people that were exposed and so forth. And it's really difficult to do that when you have a lot of transmission in the community, because the number of cases that you have to follow up their contacts just explodes, exponentially. I mean, so just being able to follow up that many people, it's very difficult. So we might be getting to a point in Connecticut where the prevalence is low enough that we might be able to do effective contact tracing. A place like Arizona, where they have sort of a ton of community transmission right now, it's probably going to be less effective. There have certainly been a lot of challenges, like everything else related to this pandemic. It's become hugely political. there have been, certain representatives who have sort of publicly said that they won't participate in contact tracing efforts. There's a guy in Maryland who had coronavirus and, flat out said he was not going to return the calls from contact tracers. And, so that sort of sets a tone for whether people are willing to participate. And if you are only capturing a fraction of the population with your contact tracing, it's not going to be very effective. So, it requires buy-in from the population and I think relatively low levels of transmission in the community. So, it's been effective in some of the Asian countries where they've done this very intensively. And they also have sort of brought technology to bear on the problem where they can, use information on your cell phone location to see what other, locations, what other cell phones you've been near. Yale actually is doing something like that, I think. They have an app that they're asking people to download on campus so they can do this type of tracing. But again, it's difficult to do in the community.
Okay, that actually leads right into sort of the next question that Jesse had. Go ahead, Jess.
Dan, so do you recall that Westport was going to use that software to be able to, I'm not 100% sure now because it's history, but to identify people who possibly had the virus or symptoms or something like that? Do you recall? I mean, those are the kinds you're not hearing that they're trying to build apps like that. That would be ideal for students coming back to school and so forth.
Yeah, I'm not familiar with what they're doing in Westport. I mean, there's certainly, there are a number of apps out there already where, they're all voluntary, obviously, and I have one on my phone actually, where you get pinged, every day or every couple of days asking if you have symptoms, and then, there's the way it's supposed to work is that, if enough people participate in this, that they can then sort of warn you if you're sort of at risk for developing the virus. I think the problem is, there are tons of these apps out there, and so for these apps to work well, you need a large proportion of the population using them, and the more apps that you have out there, the more it sort of splits the population into, the people who are willing to download one of these apps is already sort of a subset of the population, and then you start spreading them across different apps, so it becomes less and less useful. So yeah, there's been a lot of hype about sort of technological solutions. I think I'm still skeptical that there'll be a lot of help, except maybe in sort of limited situations, like maybe in workplaces or in university settings and so forth, where certainly like Yale is, I think, requiring people coming back to campus to have one of these apps on their phone. You have to check in. I get an email every day telling me, when people in my lab have gone to campus and whether they have symptoms, because they have to sort of, check whether they have symptoms or not before they enter campus. And so, certainly in limited settings where you can compel people to use the app, based on employment or attendance at school or that sort of thing, it might work, but I think it's difficult otherwise.
I do know my sister lives in Melbourne, Australia, and the whole family, they all have apps on their phone. So I will find out what that is and see what kind of data they're collecting, and see how many apps there are. That's the other thing, is where's the central database? So that's critical that it goes to the right place, right?
Yeah. So there certainly have been a lot of privacy concerns about some of these apps, and Apple and Google sort of jointly developed an app a while ago, but I think again it requires a fairly high penetrance of people using the app for it to work, and we have pretty strict privacy laws and so forth in this country, and you can't compel people to use it, so you sort of rely on their goodwill and sort of convincing people to do it. So it's challenging.
Thank you.
Thanks, Dan. If I could be self-indulgent, I have a quick question, and you don't need to go into a lot of detail because it is getting late. Has there been any evidence that the widespread and widely attended protests over the last several weeks. Has there been any evidence that there's been a spike because of that in cities where there were large demonstrations?
Not that I've seen. So I think there's, people have been looking pretty carefully at this. I mean, so there was a study in Minneapolis where they, asked people who had attended the protest to come in and give samples, and they found that the prevalence of the virus among the people who'd been at the protest was pretty similar to the general population. It's like 2% of people who got tested. It's possible that Minneapolis wasn't sort of a hotspot at that time, so it's possible that protests in areas that already had a higher prevalence might have been more of an issue, but it's pretty difficult to tease out because it's the same issue. Everybody's asking the same question about the rally in Tulsa, but it's just difficult to tease out from the background trends because Tulsa, the rates were already going like this the week before the rally there, so it's hard to say whether there was an additional bump from that without doing really careful studies of individuals.
Okay, Shoshana, all
Thank
yours.
you. Thank you. Well, yes, and I appreciate how much time you've spent with us tonight, Dan, and thank you very much. This was really interesting. And thank you everybody else for coming out as well. Watch your emails. We're going to be doing this. We have lined up every Wednesday for the next few weeks. Next week, Donna Levine, who you heard from a little bit tonight, and Mike Hurwitz are going to be talking about planning for the end of your life, which there's no really nice way to say that, but that I think is the topic. And then the following week, Mark Oppenheimer is going to talk about the work he's been doing in Pittsburgh since the Squirrel Hill shooting. And then on the 22nd, we're having a friend of mine who happens to have written a book recently about Lucy Davidovich, who was an activist and historian in the early 20th century, and she'll be talking to us about the book. So thank you again, and let me know. People can email me if you have questions, or future questions, comments, suggestions, etc. Thank you, and thanks, Dan.
Thanks for having me. Hope to see you all in person soon.
Yeah, that would be nice.
Yep.
I'm going to keep the room open for a little while. If people want to just schmooze a little themselves, feel free to hang around. Also, I did record the session. However, I'll talk to Dan whether we have permission. If anybody who participated would not like to be included, we will certainly consider not publishing the recording.
See you tomorrow.
I'm sorry? Oh, okay. Anyway, go ahead and if you want to talk for a while, if people want to ask any general questions about programming coming up or anything.
I wanted to make a comment. Did he go? Oh, Dan.
No, I'm still here.
I wanted to make a comment.
Oh, hi, Raina. Yeah.
When you were talking about overdose and depression, there was a very interesting article in the New York Times a few weeks back by Andrew Solomon, who's a reporter but has written about many interesting things about depression and COVID, and how COVID contributes to depression and vice versa. And many people have gotten depressed during being quarantined and the COVID crisis, but people who have underlying depression and are isolated have often become suicidal and committed suicide. And he was stressing the need for touching and being together may supersede the need for social distancing with such people. Just a comment.
Yeah, I think there's a lot of balancing priorities that needs to be done, and I think there are a lot of individual decisions and and considerations that need to be taken into account when we're thinking about these different policies. So I think there's no easy answers.
And mazel tov to you.
And Dan, I'm feeling protective of your time as someone who runs a lab and I'm sure goes to hundreds of meetings and has young children. Please do not feel like you have to hang around.
Yeah, I do have to go, but thank you for having me.
Thank you so much.
Yeah.